Today, we are introducing TRACEGENT, JLK's integrated platform designed to connect the full Alzheimer's disease treatment pathway, built on more than a decade of expertise in medical imaging. After years of focus in the stroke market, JLK is now applying that same capability to expand into another major clinical area, dementia. Before we begin, I would like to make one important note. TRACEGENT has completed technical development and is currently preparing for regulatory approval. For that reason, clinical or promotional terms such as ARIA and treatment can be used officially only after the appropriate approvals are obtained. This material is intended to share the technical development status of TRACEGENT, an integrated AD imaging solution. Please ensure that any terms restricted before regulatory approval are not used in external media, including news coverage. TRACEGENT combines MRI and multi-tracer PET to support precision diagnosis, risk screening, safety monitoring, and efficacy tracking. It brings 7 AI products and 4 treatment-related stages together within a single platform. Let us take a closer look at why imaging is becoming central to treatment decision-making in the era of new Alzheimer's drugs. This presentation is organized into 7 parts. We will begin with the new era in Alzheimer's treatment, then move into the TRACEGENT platform overview, the integrated decision-making workflow, the stage-based clinical workflow, real-world clinical use cases, the market expansion strategy, and finally, TRACEGENT's global differentiation. Let us begin with the first section. To understand why an integrated Alzheimer's imaging platform is needed now, we first need to look at the fundamental shift taking place in the market. Alzheimer's treatment has changed fundamentally over the past 30 years. Since donepezil was introduced in 1996, treatment had long been limited to drugs that mainly relieved symptoms. But with aducanumab in 2021, the field entered the era of antibodies designed to directly remove amyloid. Aducanumab, however, did not gain a stable position in the market because of uncertainty around efficacy and ARIA-related safety concerns, and it was withdrawn in 2024. Lecanemab followed in 2023, and donanemab in 2024. Both received full approval after showing a 27% to 29% slowing of cognitive decline. Lecanemab is already being prescribed across dozens of countries. The market is projected to reach approximately $15 billion by 2030, with annual growth of around 20%. In other words, the era of disease-modifying Alzheimer's treatment has truly arrived. However, these new drugs come with a serious adverse effect: ARIA, or amyloid-related imaging abnormalities. As the name suggests, these are abnormalities detected on MRI. These antibodies clear amyloid from the brain. In that process, amyloid deposited along vessel walls can also be removed. As the vessel walls become more fragile, plasma can leak out and cause swelling, known as ARIA-E, or blood can leak and cause microhemorrhages, known as ARIA-H. The incidence is not negligible, approximately 12% to 17% with lecanemab and 24% to 31% with donanemab. These figures come from different clinical trials, so they should not be compared directly, but they clearly show that ARIA is not rare. The key point is that these adverse effects often appear on MRI before patients notice any symptoms. That is why regular MRI evaluation before and during treatment has become essential. This is exactly where a comprehensive precision imaging platform such as TRACEGENT becomes necessary to help these drugs be used safely. We will now introduce the overall structure of TRACEGENT, the platform designed to address this need. This page introduces the 7 AI modules that make up TRACEGENT. Broadly, the platform consists of 6 MRI-based modules and 1 multi-tracer PET module. First, the 6 MRI modules. WMH evaluates white matter changes, while EPVS assesses microvascular status. ARIA-E evaluates brain edema, and ARIA-H evaluates microhemorrhages. DWI helps differentiate cerebral infarction, and BPM assesses the degree of brain atrophy. Together, these modules cover vascular status, adverse effects, and structural change. Next is multi-tracer PET. One product includes 4 tracers. Amyloid and tau are the key biomarkers that directly define Alzheimer's disease. FDG and DAT support differential diagnosis by helping distinguish other types of dementia. All of these AI modules go beyond a simple positive or negative result. They provide objective quantitative values, such as volume, count, and percentile. Next, I will explain how these 7 AI modules work together across the actual treatment pathway. In the new drug era, imaging determines the major treatment decision points. TRACEGENT is designed to support all 4 of those stages. Stage 1 is precision diagnosis. PET and BPM help confirm the 3 ADN axes and identify eligible patients. This is the first gate, where patients who should not receive treatment must be excluded. Stage 2 is risk stratification. WMH and EPVS help identify patients at high risk for ARIA before dosing begins. The goal is not to respond to adverse effects after they occur, but to reduce risk in advance. Stage 3 is safety monitoring. ARIA-E and ARIA-H monitor adverse effects, while DWI helps differentiate cerebral infarction and prevent potentially fatal misdiagnosis. Stage 4 is efficacy tracking. PET and BPM are used again to assess whether the drug is actually working. With FDG and DAT, the platform also strengthens differential diagnosis against other dementias. Most related solutions cover only 1 or 2 of these stages. TRACEGENT is different because it supports the entire process from diagnosis to efficacy tracking within a single platform. This timeline places the 4 stages directly onto the real-world treatment schedules for lecanemab and donanemab. When a patient first presents, MRI performed within the past year and baseline imaging are used to evaluate diagnosis and risk at the same time. This helps determine both whether the patient is eligible for dosing and whether treatment can begin safely. In other words, stages 1 and 2 are combined into a single patient screening step. Once dosing begins, treatment follows a biweekly infusion schedule. The key points are the MRI time points defined in the relevant guidance, before the 3rd, 5th, 7th, and 14th infusions, and optionally before the 26th infusion. At each time point, FLAIR is used to assess edema, GRE or SWI to assess microhemorrhage and hemosiderin deposition, and DWI to check for cerebral infarction. The platform also automatically tracks changes in edema diameter and microhemorrhage count. Based on those results, clinicians decide at each time point whether to continue dosing, proceed with caution, or, in severe cases, stop treatment. Over the long term, PET and BPM are used again to track target engagement and structural change, supporting efficacy assessment. The key message is this: from diagnosis to follow-up, every time point is connected within one timeline in one platform. There is no need to move between multiple solutions. The full cycle can be managed through one integrated imaging workflow. Next, I will explain the integrated decision-making workflow, how these modules work together to improve clinical accuracy. This slide brings the 4-stage framework together into a single decision-making matrix. It defines each step in the new drug prescribing process, what needs to be determined, which module provides the answer, and what objective metrics are produced. In that sense, it serves as a decision-making map for the full prescribing pathway of new Alzheimer's drugs. The core value lies in the synergy between modules and in the quantitative metrics they generate. The next slide will show how the modules cross-reference one another to improve clinical accuracy and what those outputs look like in actual numbers. This slide builds on the previous decision-making matrix by showing cross-references between modules. For example, when CAA risk from EPVS is considered together with new microhemorrhages detected by ARIA-H, clinicians can be alerted to hemorrhagic ARIA risk before it becomes clinically critical. That is a level of judgment a single module cannot provide on its own. When DWI is cross-referenced with ARIA-E, an MRI abnormality can be more confidently classified as either a drug-related adverse effect or a true cerebral infarction. This is a life-or-death distinction because the emergency response can be completely different depending on the interpretation. In addition, when PET and BPM are compared over time, clinicians can better distinguish whether reduced brain volume during treatment reflects a treatment-related change or disease progressive atrophy. This helps communicate more accurately to patients whether findings suggest response or worsening. This clinical accuracy, created through 6 cross-reference pairs, is one of TRACEGENT's key differentiators against global competitors. It is something single-function solutions cannot easily match. This slide focuses on the specific numerical outputs generated by AI across the full-cycle workflow. For diagnosis, PET provides SUVR and centiloid values, while BPM calculates cortical thickness in millimeters. For risk stratification, WMH and EPVS volumes are quantified in milliliters. For safety monitoring, the system provides counts for findings that are especially important in treatment decisions, including microhemorrhages, superficial siderosis, lacunar infarcts, and edema length. Why does this matter? In real-world interpretation, whether a patient has 4 versus 5 microhemorrhages or 9 versus 10 can change the treatment plan. But at those thresholds, visual assessment by humans can vary. TRACEGENT converts those findings into objective counts and volumes, helping ensure that the same scan leads to the same value and the same decision, regardless of who reads it. The most important message on this slide is that decisions are based not on subjective impressions, but on reproducible quantitative values. That makes dosing decisions more objective and enables more accurate comparison over time. Now let us look more closely at the stage-based clinical workflow before dosing, during dosing, and during follow-up. Before dosing, clinicians mainly need to answer 3 key questions. First, what type of dementia is this? Because anti-amyloid treatment is used for Alzheimer's disease, FDG and DAT PET are used to help rule out frontotemporal dementia, Lewy body dementia, and Parkinson's disease dementia. This step helps confirm that the patient truly has AD. Second, is the patient eligible for treatment? Amyloid positivity is quantified using SUVR and centiloid values from amyloid PET. This is the first gate for anti-amyloid treatment. Tau PET then helps assess disease stage using Braak staging. Third, is the brain safe for treatment? WMH establishes the degree of white matter change. EPVS evaluates microvascular and CAA vulnerability, and BPM establishes the atrophy baseline. Together, these help identify patients at higher risk for ARIA before dosing begins. In summary, TRACEGENT quantifies the 3 standard diagnostic axes plus vascular status as a 4th axis, while also supporting differential diagnosis with a single imaging set. The TRACEGENT platform provides integrated guidance for every major question before dosing. Once dosing begins, MRI is no longer optional. It becomes a required part of the workflow because defined MRI follow-up time points are required. For lecanemab, in addition to baseline imaging, MRI is required before the 3rd, 5th, 7th, and 14th infusions. For donanemab, MRI is required before the 2nd, 3rd, 4th, and 7th infusions. For reference, the 3rd infusion MRI time point for lecanemab was added to help detect ARIA earlier. At these stages, 2 questions matter most. Has an adverse effect occurred, and is the change clinically meaningful? At every follow-up point, TRACEGENT automatically calculates changes compared with baseline. ARIA quantifies the volume of new edema and provides key evidence for decisions such as treatment interruption or dose adjustment. ARIA-H precisely tracks changes in new microhemorrhages and hemosiderin deposition, showing cumulative hemorrhagic burden as a numerical value. To emphasize the point again, this MRI schedule is not simply a recommendation. It is a required part of treatment monitoring. As anti-amyloid prescribing increases, imaging demand will increase with it, and TRACEGENT was designed specifically for this mandatory follow-up workflow. At this stage, 2 issues are especially important. Is this edema a drug-related adverse effect or a true cerebral infarction, and is the treatment working? First, differential diagnosis. When edema appears on MRI during dosing, clinicians face a critical decision point. Is it ARIA, or is it acute cerebral infarction? Both can appear bright on flare, but DWI and ADC can separate them clearly. ARIA does not show diffusion restriction, whereas cerebral infarction shows clear diffusion restriction. Why is the single distinction so important? Because the next step can be completely different: stopping treatment, administering thrombolysis, or observing the patient. If ARIA is mistaken for cerebral infarction and TPA, a thrombolytic agent, is administered, the result can be fatal hemorrhage. This type of misdiagnosis was central to a reported death case involving lecanemab. That is why accurate DWI-based differentiation can be important enough to affect survival. Based on more than 10 years of expertise, JLK has developed JLK DWI, which has been designated as an innovative medical technology and validated in leading publications worldwide. JLK's strength in MRI AI research is a major advantage, even when compared with the United States and Europe. Next is efficacy. Over the long term, efficacy is assessed from multiple angles using multi-tracer imaging, amyloid clearance to inform whether retreatment may be needed, changes in tau burden to assess long-term effect, FDG metabolic recovery to assess functional effect, and BPM and WMH to track neurodegenerative burden. In short, whether the drug is working is evaluated across 3 layers at the same time: molecular, functional, and structural. This example explains the previous 3 stages through the journey of one patient. If we follow the number of microhemorrhages over time, the entire decision-making process becomes clear. At treatment initiation, this patient had 3 microhemorrhages. Treatment continued, and the next MRI showed 0 new lesions. Because the count had not increased, the patient was considered stable, and dosing continued. As follow-up continued, the number of microhemorrhages increased to 5. On the next MRI, 1 additional lesion appeared, bringing the cumulative total to 6. That increase served as a signal to temporarily hold dosing and begin ARIA management. Monitoring then continued. On the next MRI, there were 0 new lesions, and the cumulative count remained at 6. Once it was confirmed that the finding was no longer progressing, dosing could be safely resumed. If the lesions had continued to increase, discontinuation would have been considered. The key point is this: continue, hold, resume, or discontinue. Each of these decisions is guided by a countable value: how many microhemorrhages have increased. The decision pathway is not based on subjective judgment that may differ from reader to reader. It is guided by objective change in lesion count. That is why accurate quantification matters. With precise counts, the presence of an adverse effect does not automatically mean permanent discontinuation. Clinicians can make a more nuanced decision: pause temporarily, observe, and restart if it is safe. This helps protect the patient's treatment opportunity while maintaining safety. However, comparing these counts accurately requires MRI at every time point, and the imaging workflow is complex and burdensome. The process becomes even more complicated because there are many important variables beyond microhemorrhage, including edema, intracerebral hemorrhage, lacunar infarction, and superficial siderosis. This is exactly the kind of complex, high-stakes workflow where AI-based TRACEGENT can demonstrate its true value. Next, we will show real-world clinical use cases and the TRACEGENT platform interface. This screen shows the AI analysis process in TRACEGENT. The process begins with patient selection. AI analyzes amyloid PET to identify early Alzheimer's disease, from mild cognitive impairment to early dementia. BPM, WMH, EPVS, and ARIA modules are then added to help identify patients who are appropriate for dosing. Once dosing begins, MRI is performed regularly. AI analyzes FLAIR, SWI, and DWI and automatically generates an ARIA report. The important point is that the system retrieves prior results and compares them each time. Based on that comparison, clinicians decide whether to continue or stop dosing, and PET is used to assess treatment response. In other words, screening, dosing, monitoring, comparison with prior results, renewed decision-making, and response assessment are all connected in one continuous loop within a single system. Clinicians do not have to start from scratch at every visit. They can make decisions based on AI-organized results, with comparisons already completed. First, AI automatically classifies incoming imaging sequences. Clinicians do not need to manually identify which sequence is FLAIR and which is SWI. Second, analysis results can be viewed by sequence and by solution on a single screen. Results from 6 modules are not scattered across separate places, they are brought together in one view. Third, results can be reviewed along a timeline, and powerful search makes it possible to quickly find the desired time point or item. The key point is that TRACEGENT is not only analytically strong, it is designed as a usable product that fits the actual reading workflow. It is not just an algorithm, it includes the practical workflow features clinicians need to use every day. This is the timeline interface for the same patient. In anti-amyloid treatment, the most important factor is not a single image. It is change over time. This screen is designed to show exactly that. All imaging history for one patient is displayed in chronological order, with a summary of analysis results for each time point. Changes from prior values, for example, microhemorrhage count or edema volume, are visualized as graphs, allowing clinicians to compare disease progression and treatment response trends at a glance. If a specific time point needs to be reviewed, the clinician can simply click that point and go directly to the detailed analysis from that visit. In other words, the data are no longer scattered imaging studies. They become a precise longitudinal trajectory for one patient. The earlier example of microhemorrhages increasing from 3 to 6 can be read clearly as a single trend line on this screen. This screen shows the full set of quantitative values extracted by AI from imaging at a single time point. All indicators needed for diagnosis, risk assessment, and safety are presented together as objective numbers. We will show the details in the live demo. This slide shows longitudinal analysis, how those values change over time, with a focus on ARIA, which is most directly linked to treatment decisions. For ARIA-E, the system analyzes and visualizes changes in edema volume and diameter at each follow-up point. For ARIA-H, it tracks changes in the number of microhemorrhages and superficial siderosis findings in the same way. There are two key points here. First, the system does more than show change. It automatically assigns severity grades based on clinical guidelines. Depending on edema diameter or the number of microhemorrhages, findings are classified as mild, moderate, or severe. Second, the results are automatically generated into a report. Why is this important? Threshold decisions, such as whether there are 4 or 5 lesions, or 9 or 10, are difficult and inconsistent when clinicians have to count and grade findings manually every time. TRACEGENT automates this process using objective quantitative values and guideline-based criteria, improving both consistency and speed in interpretation. Now, we will show the features discussed so far through a live demo. Throughout this presentation, we have discussed how the TRACEGENT platform connects the entire Alzheimer's treatment pathway across 4 stages: precision diagnosis, risk stratification, safety monitoring, and efficacy tracking. We also explained how these stages work together to create clinical synergy. Now, I will show you how these 4 stages actually operate in a real clinical workflow, and more importantly, how each module does not work in isolation. Instead, the modules cross-reference one another to improve clinical accuracy. As soon as imaging data are uploaded, the TRACEGENT platform automatically classifies the imaging sequences and applies the appropriate AI solution to each sequence. The platform includes 7 AI solutions: JLK-PET, JLK-BPM, JLK-WMH, JLK-PVS, JLK-ARIA-E, JLK-ARIA-H, and JLK-DWI. The key point is that TRACEGENT does not simply list these results separately. It integrates them through cross-module validation to generate a single, clinically meaningful insight. This is not just a simple sum of individual AI functions. It is the unique value that only TRACEGENT, as an integrated Alzheimer's treatment platform, can provide. Now, I will walk you through each stage step by step. The first stage is precision diagnosis. This is a stage where we precisely identify patients who may be eligible for treatment. As you can see on the screen, the JLK-BPM analysis shows that this patient's cortical thickness is significantly reduced compared with the normal reference distribution for the same age and sex group. This provides objective quantitative evidence of structural neurodegeneration. Now we cross-reference this with JLK-PET. Both amyloid and tau PET were positive, supporting Alzheimer's disease pathology. This is the first cross-reference point. By simultaneously quantifying structural atrophy through JLK-BPM and amyloid and tau deposition through JLK-PET, TRACEGENT provides comprehensive imaging-based coverage of the 3 core AD diagnostic axes: amyloid, tau, and neurodegeneration. In this case, the patient meets the imaging criteria for typical Alzheimer's disease. By providing both neurodegenerative changes and pathological biomarkers within a single platform, TRACEGENT helps specialists confidently identify patients who are appropriate candidates for treatment. The second stage is risk stratification. At this stage, we determine whether the selected patient has a brain that is safe to treat. This is done through the second cross-reference. JLK-WMH quantifies white matter hyperintensities using the Fazekas grade, while JLK-PVS quantifies the number of enlarged perivascular spaces in the centrum semiovale. In this patient, the WMH analysis shows Fazekas grade 1, and the number of EPVS in the centrum semiovale is fewer than 20 per hemisphere. This indicates a very low burden of small vessel disease. When these two modules are cross-referenced, TRACEGENT provides a multi-axis assessment of Fazekas-based white matter disease and glymphatic or CAA vulnerability. Based on the Boston criteria, this patient does not fall into the high-risk group for ARIA. In this way, TRACEGENT quantitatively evaluates risk factors for treatment-related adverse events before dosing, supporting a safer clinical decision when determining whether to proceed with treatment. The third stage is safety monitoring. Once treatment begins, one of the most critical decision points emerges. When an abnormal signal appears on follow-up FLAIR MRI, clinicians must immediately determine whether it represents drug-related ARIA or acute cerebral infarction. If this is misinterpreted, the emergency management pathway can go in the completely opposite direction. In the worst case, it can directly affect patient survival. As shown on the screen, the JLK-DWI analysis confirms that this is not acute cerebral infarction, as the restricted diffusion lesion volume is 0. At the same time, JLK-ARIA accurately identifies the increase in new-onset edema. It automatically calculates changes in edema volume and diameter compared with the prior scan, as well as the severity grade, which is moderate in this case. This is the emergency differentiation cross-reference we discussed on slide 12. By integrating JLK-DWI and JLK-ARIA, TRACEGENT determines whether the FLAIR hyperintensity represents a drug-related adverse event or an acute ischemic stroke, helping prevent critical misdiagnosis at the source. Furthermore, when cross-referenced with the JLK-WMH baseline, TRACEGENT can distinguish chronic white matter disease from new-onset edema. This supports precision edema differentiation and enables a more nuanced decision, such as temporary treatment interruption followed by treatment resumption, rather than immediate permanent discontinuation. Now, I will briefly show how clinicians can directly review and validate the AI results in more detail. TRACEGENT's medical imaging viewer goes beyond a standard DICOM viewer. It allows radiologists and specialists to directly perform quantitative measurements and labeling within the viewer. For example, on GRE or SWI images, the physician can directly confirm and measure the number and size of cerebral microbleeds, or CMBs. For edema, the physician can measure the diameter and immediately compare the change from the previous time point. Because the system objectively fixes values such as how many lesions have increased and how many millimeters the edema has grown, the same findings can lead to the same numerical values, the same severity grade, and the same clinical decision. In other words, the AI results shown earlier on slide 18 can be further reviewed, refined, edited, and finalized by the specialist within this viewer. This demonstrates one of TRACEGENT's key strengths. AI is not a black box. It is a clinically controlled and physician-validated tool. The fourth stage is efficacy tracking. This is the stage where treatment response is monitored and the clinical effect is objectively demonstrated. When we click on the screen, the patient's imaging timeline appears. By selecting each time point, we can open the detailed information and review the corresponding imaging results and AI results. When we click the AI button on the right, we can access more detailed AI results, including quantitative graphs. In this patient, RAE occurred after treatment, but gradually improved over time. On the longitudinal graph, the edema diameter reaches a peak and then returns to 0, making the recovery trajectory immediately visible. At the same time, the JLK PET centiloid value gradually decreases over time, confirming target engagement. In this way, all longitudinal follow-up data are automatically collected within TRACEGENT and converted into a standardized infographic report, visually demonstrating treatment response. When JLK PET and JLK BPM are longitudinally cross-referenced, TRACEGENT tracks amyloid and tau clearance together with structural changes. This makes it possible to distinguish treatment-related volume changes from disease-related atrophy and to provide patient-specific prognostic assessment. TRACEGENT quantitatively compares imaging before and after treatment, objectively demonstrating pathological improvement that is difficult to confirm by visual assessment alone. Furthermore, all of these quantitative results can be automatically generated into purpose-specific interpretation reports, which can be used directly for the specialist's final assessment and for patient communication. This allows both clinicians and patients to understand and trust the treatment outcome. To summarize, the live demo you just saw demonstrates two key points we discussed in the presentation. First, TRACEGENT connects the full Alzheimer's treatment continuum within a single platform: precision patient selection, safety evaluation, adverse event monitoring, and final efficacy verification. Second, the platform's clinical accuracy does not come from individual modules working separately. It comes from cross-referencing between modules. This is the core differentiator of TRACEGENT compared with single-function solutions and global competitors. This concludes the TRACEGENT platform demonstration. Now that we have completed the live demo, I will return to the presentation and explain how the TRACEGENT platform can expand into the broader dementia market. This is the technical and strategic market expansion strategy. The key message is that the core algorithms developed for Alzheimer's disease are also the key to entering the broader dementia market. In other words, expansion does not require entirely new R&D. The platform is structured to minimize additional R&D by reusing core algorithms that have already been developed. As a result, TRACEGENT can cover more than 90% of the overall dementia clinical pathway while keeping additional development to a minimum. The conclusion is that the same platform, using nearly the same modules, can expand the total addressable market by approximately 1.5 times. This roadmap shows the sequence for market expansion. It unfolds in 4 stages. Stage 1 is the blockbuster era. This is the current stage, where TRACEGENT first targets the mandatory MRI market created by new AD drugs. Stage 2 is vascular activation. The already operational WMH and EPVS modules are activated for the vascular dementia workflow. Stage 3 is DLB differential. DAT PET-based differential diagnosis is expanded to Lewy body dementia and Parkinson's disease dementia, with clinical decision support added. Stage 4 is dementia standard. All 7 modules are integrated, real-world data are accumulated, and TRACEGENT becomes standard infrastructure for memory clinics. By fully leveraging existing modules and minimizing additional R&D, TRACEGENT can begin with AD, which represents 60% to 70% of dementia, and expand toward coverage of more than 90% of the overall dementia market. In other words, using the new Alzheimer's drug market as a springboard, TRACEGENT can become a standard platform for dementia imaging overall. Finally, let us summarize the core advantages that can help TRACEGENT defend its position against global competitors. There are already global brain imaging AI companies in the market, but TRACEGENT is fundamentally different in 4 ways. First, it is a platform built for the anti-amyloid new drug era. It is positioned to align with the expansion of the lecanemab and donanemab markets. Second, and most importantly, it is an all-in-one, full-cycle platform. Competitors are generally focused on single-function products, while TRACEGENT supports the entire process in one platform: diagnosis, risk stratification, safety monitoring, and efficacy tracking. Third is regulatory fit. TRACEGENT directly supports the MRI monitoring and amyloid quantification required by global guidelines. Fourth is scalability. Beyond Alzheimer's disease, the same platform can expand into vascular dementia, Lewy body dementia, and Parkinson's disease dementia. In the global dementia market, TRACEGENT is positioned to become a central platform connecting diagnosis through follow-up. This integrated platform approach will be one of JLK's key competitive advantages, one that single-function solutions cannot easily match. Going forward, TRACEGENT will play a central role in supporting clinicians' treatment decisions in the era of new Alzheimer's drugs, while continuing to expand and grow within the dementia market. Today, through this announcement of TRACEGENT platform technical development, JLK is pleased to officially declare its expansion into the dementia market. JLK will continue working to make TRACEGENT a valuable platform that can benefit more people. For any additional inquiries, please contact JLK. Thank you.